So good afternoon and welcome to this new ERKNet webinar. My name is Francesco. I'm speaking from my office in Rome. As always, before starting, I remind you that your microphones are turned off. That during and after the webinar, you can send your question through the GoToWebinar application that appears on your screen, and I will ask your questions at the end of the presentation. The webinar will last approximately 30 minutes. We will then have 15 minutes available for questions. So our speaker today is Carlo Dionisi Vici. Carlo is a friend. He is also a pediatrician, and he is currently the head of the Division of Metabolic Disease and Hepatology here at the Bambino Gesù Children's Hospital in Rome. Carlo has always been very involved in translational research on inborn errors of metabolism, and he's been focusing on acute and long-term management of this disease. He's a very well-known metabolic disease in the metabolic community. He's one of the leading physicians in Europe. He is also very much involved in liver transplantation for metabolic inborn metabolic diseases, and he has a lab which is involved in technologies, in developing technologies to improve diagnostic processes. He's analyzing biomarkers, performing metabolic studies to decipher disease physiopathology, and is having since now many years is particularly involved in newborn screening here in Italy and in the development of international guidelines. As you can see here in his opening slide, he is an active member of a sister ERN, the MetabERN network, and has published, I think, more than 350 papers. Now, the title of his talk today is Lysinuric protein intolerance, which is a disease where he had, in which he has an interest since many years. And thank you, Carlo, for accepting our invitation. Please.
Thank you, Francesco, very much for your kind introduction, and thank you for the opportunity to share this webinar together with ERKNet, but also with MetabERN. Today we are talking about a metabolic disease, in particular a disorder of amino acid transport that is called Lysinuric protein intolerance. It is an autosomal recessive disease due to mutation in the transporter of cationic amino acid that is called Y plus LAT1, that is coded by a gene SLC7A7 that is located on chromosome 14. And a mutation, loss of function mutation in this gene causes a reduced intestinal absorption of the three dibasic amino acids, the cationic amino acid lysine, arginine, and ornithine, but also reduced tubular reabsorption with an increased excretion in the urine of the three amino acids. And all these changes result in a functional defect of the urea cycle. It is important to notice that the Y plus LAT1 protein heterodimerizes with another protein to express the whole system Y plus LAT1. But why an ERKNet dedicated webinar dedicated to Lysinuric protein intolerance? I want to share you and to remember that there are some antenatal manifestations in a well-known nephropathic disease that is called cystinuria. And in the prenatal ultrasound, you can see, especially in the third trimesters, the presence of an hyperechogenic colon. And this especially may lead to the diagnosis, to the prenatal diagnosis of cystinuria, especially in families with an history of lithiasis and renal failure. And notably, the antenatal biochemical expression of cystinuria is also have been seen in amniotic fluid, showing an elevation not only of alcysteine but also of the three dibasic amino acid. So probably in cystinuria, cysteine may accumulate in the colon because it's not reabsorbed in the small intestine, thereby producing the hyperechogenic period of the colon in the third trimester of pregnancy. But more recently, it has been shown that not only cystinuria can lead to the presence of colonic hyperechonicity, prenatal colonic hyperechonicity, but also lysinuric protein intolerance that shares with cystinuria the 3 dibasic amino acids. So probably the mechanism causing the hyperechogenicity in cystinuria and in lysinuric protein intolerance is probably the same as this is connected to an abnormal transport of the dibasic amino acid and also of cysteine. But the second reason why we have a net webinar on LPI is a more recent article appearing in Pediatric Nephrology in relation to a surprising cause of proteinuria. And this is the story of a 16-year-old patient that, after following an high fever, presented darkening of urine. But in this former history, he had a story of IG immune infusion therapy for transient hypogammaglobulinemia. He had also persistent elevation of high ferritin levels, growth retardation, osteoporosis, and hepatosplenomegaly with no diagnosis. At the time of the age of 16, he presented after fever with a neuroanalysis with a massive proteinuria, but also had elevation of antinuclear antibodies and a reduction of complement. And bone marrow showed a macrophage actively phagocytizing hematopoietic stem cells. And the differential diagnosis of this patient was or hemophagocytic lymphohistiocytosis, but also a systemic juvenile idiopathic arthritis or a systemic lupus erythematosus. But the real diagnosis was lysinuric protein intolerance. So, in the conclusion of this article was that patients with lysinuric protein intolerance have a marked tendency to develop immunological diseases. And now, lysinuric protein intolerance is listed among the primary causes, through the primary genetic causes of hemophagocytic lymphohistiocytosis, a disease with both the nephrology community is somehow familiar. But back to the classification of urea cycle and urea cycle related disorders, we have the primary urea cycle disorders that are due to the defects in the 6 enzymes and the 2 transporters related to the urea cycle, but hyperammonemia is also shared by many other conditions, including inherited and acquired condition that can cause hyperammonemia, similarly to what's seen in urea cycle disorder, and amino acidopathies can lead to hyperammonemia, and lysinuric protein belongs to the categories of amino acidopathies. Lysinuric protein intolerance in polarized cells, as are the intestinal or the tubular renal cells, is causes, as we have already heard about it, an reduced intestinal absorption and the reduced tubular reabsorption of the 3 dibasic amino acid, and consequently in plasma we have reduced levels or reduced circulating levels of lysine, arginine, and ornithine, and increased ammonia, of course, because of the secondary dysfunction of the urea cycle. And in urine, we have a dibasic amino acid urea with lysine, ornithine, arginine, and ornithine, but also as a consequence of the impaired function of the mitochondrial part of this urea cycle, we have also orotic acid urea. Clinically, the urea cycle defects and the related disorders present many similarities, including episodic lethargy with hyperammonemic coma also. And here you see that lysinuric protein intolerance, different from the majority of these diseases, presents with chronic inflammation, but also with a kidney disease. So lysinuric protein intolerance is a paradigmatic example of a multi-system metabolic disease sharing similarities with urea cycle, but also presenting some unique features like chronic inflammation and also the kidney disease. This is a list of the clinical manifestation in lysinuric protein intolerance. The patient have an aversion to protein-rich food in relation to the impairment of the urea cycle. So they present recurrent vomiting, very frequent failure to thrive. Neurologically, they can have lethargy, coma, and mental retardation. And lethargy and coma are, of course, related to the hyperammonemic crisis that can characterize the clinical course of patients with LPI. At the skeletal level, the patient presents osteoporosis and also spontaneous fractures. But more importantly, these are a sort of peculiarity related to the inflammatory signs in lysinuric protein intolerance. There are clear and very severe lung changes. In particular, there are interstitial changes with fibrosis, leading in the most severe cases to pulmonary alveolar proteinosis. At renal level, the patient presents proximal tubular dysfunction with an overt Fanconi syndrome, but also they can have a glomerular dysfunction with focal glomerulosclerosis and tubulointerstitial nephritis, leading to chronic renal failure and making several patients, especially after adolescence, to end-stage liver kidney disease. At a level of the immune and hematological system, the patient we've seen they could have they can present with overt hemophagocytic lymphohistiocytosis, but also with some changes, probably less severe, that are very similar to the macrophage activation syndrome. And the characteristic immunological features of this patient is the elevation. We have seen that the patient biochemically they present reduced levels, circulating levels of the free dibasic amino acid, but also they have elevation, classically elevation of LDH, of ferritin, of triglycerides, and very frequently they have leukopenia, thrombocytopenia, and immunological testing, the most sophisticated testing, shows reduced NK activity similar to what's seen in macrophage activation syndrome or in systemic juvenile rheumatoid arthritis, with reduced numbers of CD4 and CD and increased CD8 with an inverted CD4-CD8 ratio, and very importantly, a baseline lymphocyte stimulation index. It means that these patients are overactivated in the terms of inflammation. And a trigger that can cause very severe inflammatory signs is the varicella infection. This is the cases, two patients reported many years ago by the Finnish group of reporting two patients that a baseline level, as you can see, of very much elevated LDH and ferritin with mild anemia in one patient, but during varicella infection, they manifested an overt activation of the macrophage system with double levels and 6 times levels increase of LDH, increase of ferritin, anemia, thrombocytopenia, and also systemic signs like proteinuria, hyperbuminemia, edema, and interstitial pneumopathy. While in the second patient, he had hemoptosis, hemolysis, abdominal pain, interstitial pneumopathy, again proteinuria, hematuria, edema, and hyperbuminemia. And importantly, this patient presented after varicella vaccination or varicella infection, very low titers of antibody against varicella. And this is a patient that we have seen many years ago presenting with a sudden post-viral infection. You see that he had a clear discoloration of the hair, severe skin manifestation resembling those of systemic lupus erythematosus, skin scaling, and also here the bone marrow shows the characteristic finding of hemophagocytic lymphohistiocytosis. And following the infusion of immunoglobulin, he had a complete recovery of the skin and inflammatory signs, but signs of immune deficiency persisted with reduced lymphocytes and in particular reduced CD3 and CD4 cells, and also CD8. So it means that this patient had a sort of lupus-like acute presentation following a viral infection, probably similar to what's seen after varicella infection in the two Finnish patients. And this was, again, another experience we had many years ago, about 20 years ago, in a patient presenting an end-stage pulmonary alveolar proteinosis. And for this reason, he was attempted to have a combined heart and lung transplantation. But following a few months following the transplantation, the pulmonary alveolar proteinosis relapses in the donor lung. So it means that the disease was not related to the tissue of the patient, but was related to something that colonized the tissue of the patient. And in particular, the problem was related to what is now consistently defined, that the target organs for lysinuric protein intolerance are the lung, the kidney, the bone, the liver, the spleen, the immune system, and the brain. And the fil rouge that connects all these systems is the reticular endothelial system that is present in all target organs. Therefore, the macrophage is probably the target cell in lysinuric protein intolerance. So all this clinical history shows that macrophage plays a really important role in the clinical manifestation of lysinuric protein intolerance, in particular in the systemic clinical manifestation of LPI. And to confirm this, the alveolar macrophages from the bronchoalveolar lavage from a patient with LPI expressed the protein, the SLC7A7. And this patient also had reduced activity, reduced phagocytic capacity and monocyte-derived macrophages with reduced phagocytosis that prevents the anti-inflammatory response that also prevent the autoimmune response. So it is clear that the macrophages and the white blood cells are involved in the clinical manifestation, the systemic clinical manifestations of LPI. And to this regard, the LPI patient have a very high levels of plasma calprotectin. You see here, this is a series of 10 patients, again from Finland, where there is a cluster of this disease. And you see this patient presenting also with reduced glomerular filtration rate, with increased excretion of beta-2 microglobulin, and characteristically, and we will discuss later, this patient always have an elevation, a mild elevation of citrulline, but plasma calprotectin, you can see here, is extremely elevated in LPI patient, regardless of the clinical condition. And we have seen also in our patients a clear increase of calprotectin in comparison to patients presenting with systemic juvenile arthritis, active or inactive, and also in relation to patients with autoimmune diseases. But you can see here that the three samples from patients without inflammatory signs in our series have the lowest level compared to the ones showing the highest level, and all these patients had clear signs of systemic inflammation. And calprotectin is elevated in inflammation and increases in various inflammatory or autoimmune diseases. The source of release is secreted by activated monocytes and granulocytes during inflammation, and there is a pro-inflammatory function since it is the endogenous ligand for Toll-like receptor 4 that amplifies the inflammatory response. And what are the relationship between LPI and Toll-like receptor pathway? And again, the Finnish group showed that there is a dysfunction in macrophage toll-like receptor signaling caused by LPI. In particular, the patient presented increase of IL-12 and IL-1RA after following toll-like receptor 4 stimulation, the toll-like receptor that is connected with calprotectin. Patients also presented increased secretion of TNF-alpha, IL-12, and IL-1RA following toll-like receptor 2 and 1 stimulation, while there was a downregulation or an impaired response to toll-like receptor 9 stimulation. And the conclusion of this article is that macrophage plays an important role in the pathogenesis of lysinuric protein intolerance, and that cationic amino acid transport plays also an important role in the regulation of innate immunity response. And LPA macrophages secreting higher level of interleukin and of TNF indicates that patients develop a stronger inflammatory response when the macrophage confront with pathogens. So LPA response to bacterial infection is stronger than the one we observe in healthy individuals. And accordingly, the bone disease in lysinuric protein intolerance was also favorized or sustained by a chronic inflammation, as seen here in these two patients presented at bone densitometry, very low Z-score here and here, and in relation to the levels of ferritin. And so there is a clear cross-talking between inflammation and bone disease, as known in many other conditions like systemic arthritis, juvenile rheumatoid arthritis. So lysinuric protein intolerance is not only a disease of polarized cells, but is also a disease of non-polarized cells. And this is very important because so far the focus of the attention in relation to LPI was related to renal and intestinal function of polarized cells, but also non-polarized cells express the transporter, and there are many of the clinical cascade that are related to the abnormal transport of the dibasic amino acid in non-polarized cells. And to this regard, you see that the mRNA expression of the tissue expression of the transporter of the basic amino acid SLC7A7 is mainly expressed in white blood cells and in lymph node. So it means that the target tissue for this transporter is not only the polarized cells, but also the non-polarized cells and the hematopoietic system. But back to the biochemical indicator or the biomarker related to lysinuric protein intolerance, you see that patients present with hyperammonemia. They have high glutamine, very similar to the rest of urea cycle defects. They have orotic aciduria, as seen in the OTC, in citrullinemia, in Triple H syndrome, or in arginine. But also they have mild increase of citrulline, and this is shared with citrullinemia, with argininosuccinic aciduria, and with citrine deficiency. And why this patient with the functional defect of the urea cycle present with an elevation of citrulline? And the elevation of citrulline, you see this is a series of patients, is clearly present regardless of the age of patient. You see these are 7 patients followed at the Bambino Gesù hospital. You see their age ranges between 1 year to 31 years. They clearly present an elevation of LDH. They have variable increase of ferritin, but citrulline, with the exception of 1 patient, is always mildly elevated. And now citrulline at newborn screening, the mild elevation of citrulline at newborn screening can pick it up also patient with LPI, as we have recently published in collaboration with the colleagues of Florence that had shared with us some of these patients. But citrulline is, why citrulline is elevated in a functional defect of the urea cycle? So arginine is the key player of this metabolic pathway. You see that there is a clear interplay between arginine and ornithine into the urea cycle, and citrulline is produced within the urea cycle. Here you see that citrulline is produced by the fusion of ornithine with carbamyl phosphate, but also arginine is involved in other pathways, in particular in not only in the urea synthesis, but also in creatine synthesis, in polyamines, in nitric oxide synthesis, you see here, in proline, glutamate, and agmatine metabolism. And what about arginine and citrulline in lysinuric protein intolerance? We can see here that patients with lysinuric protein intolerance in their fibroblasts had an increased arginine uptake. The problem in non-polarized cells is that there is a reduced efflux, but there is an increased uptake within the cells. And the same happens also in macrophages. You can see that patients present an elevation of arginine within the macrophages. So there is an intracellular storage or an intracellular excess of arginine that can produce or can activate different pathways. And you can see here that creatine in lysinuric protein intolerance is more elevated in comparison to other urea cycle defects. This is the levels, the normal level of creatine in plasma, and you see that lysinuric protein intolerance patients have an elevation of creatine, meaning that arginine is shifted to the creatine synthesis. The excess of intracellular arginine is shifted into creatine synthesis. But also arginine is the precursor for the synthesis of nitric oxide, and you see that the increased, we have proven together with Francesco in this paper that within fibroblasts there is an increased production of nitric oxide. And these are the putative metabolic fates of arginine in relation to the whole pathway that connects the synthesis of nitric oxide and arginase in immune cells. But back to our finding, it's clear that arginine is shifted to the synthesis of creatine, as seen here, but also is shifted to the synthesis of NO. And we have seen in vivo in our patient that there is an increased levels of NO3 concentration. You see that in 3 patients with LPI, the NO3 concentration was about double what's seen in controls. And in the patient presenting this lupus-like presentation, when he was unwell, he has a clear elevation of NO3, and that returned to almost normal level when he was free of these inflammatory signs. So it's probably the metabolism of NO participate to the immune dysfunction in lysinuric protein intolerance. And this is confirmed by the key role played by arginine in the modulation of the macrophages phenotype. So when the macrophages are activated in a pro-inflammatory way, the arginine, the intracellular arginine, is shifted to the formation of nitric oxide through the activation of the nitric oxide synthase. And in parallel with the synthesis of NO, there is an equimolar production of citrulline. So it means that the elevation of citrulline that we observe in lysinuric protein intolerance very likely depend from an activation of the nitric oxide synthase in different tissues, leading to an increased production of citrulline. And this explains why citrulline is elevated despite the malfunction of the urea cycle. So the citrulline produced in lysinuric protein intolerance is not related to the urea cycle, but is related to the activation of the NO pathway. And of course, on the other side, when the macrophages are in N2 phenotype, so the anti-inflammatory phenotype, the intracellular arginine is shifted to the formation of ornithine through the activation of the arginase, the enzyme that converts arginine into urea and ornithine. So the putative role of macrophages in lysinuric protein intolerance is this one. A trigger infection, like varicella infection, increases the production of interferon gamma, which shift the profile of the macrophages into the M1 phenotype. And the M1 phenotype causes the production of NO and, of course, of citrulline. And the excess of NO on one side activate the production of interleukins, of cytokines, and the production of also of nitrites and nitrates, with the cascade, the activation of production of peroxynitrates, blocking T cell cycling, increasing cytotoxicity, and creating an abnormal crosstalk between T cells and macrophages, then leading to a reduced phagocytosis. The excess of citrulline can also produce post-translational protein modification or protein citrullination that is characteristic of autoimmunity and of inflammation. Therefore, the conclusion of this paper that we had the chance to publish about 10 years ago together with two good friends from the Necker Hospital, Hélène Auger and Manuel Schiff, was that lysinuric protein intolerance is a multi-organ disease by far more complex than a classical urea cycle disorder. You see here at the top of the pathway of the cascade, the Y+ system defect impairs the epithelial lysin, arginine, and ornithine efflux. Epithelial means the polarized cells, causing reduced intestinal absorption and reduced tubular reabsorption with a cationic amino acid deficiency, secondary cationic amino acid deficiency, which can lead to protein malnutrition, to growth failure, and to osteopenia. But we shouldn't forget that osteopenia is also connected with hyperinflammatory states. The reduced availability of cationic amino acid may impair secondarily the urea cycle, probably in relation to a reduced availability of ornithine, and this causes the hyperammonemia. But on the other side, in non-polarized cells like macrophages, the excess of arginine can activate the production of nitric oxide, and the production of nitric oxide can be the starting point that causes the hemophagocytic lymphohistiocytosis that can cause renal disease, pulmonary alveolar proteinosis, and immune dysfunction and autoimmunity. On the other side, in non-stimulated LPI macrophages, so it means that we need a trigger to activate all this pathway. In non-stimulated LPA macrophages in culture medium, there was a decreased, you see, levels of nitric oxide. This is something this is against the theory that I presented so far, but of course, this is a category of cells that were not stimulated. So it remains still debated if all this story related to arginine shifted to nitric oxide should be still proven, and we have an active research with the colleagues of our rheumatology laboratory and investigating in this pathway. But what about the treatment of lysinuric protein intolerance? To treat the urea cycle defect, the patient needs a low protein diet. In the majority of cases, there is a self-selected low protein diet. Of course, we need to refeed the urea cycle by providing substrates that are missing, and we cannot provide arginine as a substrate because it's not absorbed. It means that we have to provide substrate food for the urea cycle by giving citrulline, and also the patient to reduce the ammonia are treated with nitrogen scavengers like sodium benzoate or sodium phenylbutyrate. And to treat growth failure and osteopenia, many of these patients have reduced the GH secretion. So for this patient, or the GH is not fully active, and some of these patients are treated with GH supplementation. And again, to treat the osteopenia, probably there is also a connection with the lysine deficiency. So lysine supplementation can improve the osteopenia. And patient can also be treated by supplementing with, of course, vitamin D, calcium, but also alendronate. But there are concerns about the risk of increasing nephrocalcinosis. And for the immune dysfunction, the prevention of the infection, so large problem of immunization, in some cases, in overt cases, presenting acute immunological dysfunction, immunoglobulin infusion have been attempted, and also immunosuppression. And to treat alveolar proteinosis, of course, absolutely there is a contraindication to lung transplantation, but bronchoalveolar lavage and steroids have been attempted, and also inhaled GM-CSF has been attempted. And to treat interstitial pneumonia, renal disease, and autoimmunity, immunoglobulin infusion, steroid, and immunosuppression, with some concern about the use of cyclosporin and mycophenolate mofetil. Sorry, I had a problem. Okay. But again, if the target cell of LPI is the macrophages, there is one report that showing that the treatment of systemic lupus erythematosus-like in a patient with lysinuric protein intolerance was very well treated by hematopoietic cell transplantation. You see the levels before transplantation. You see the patient have anemia, thrombocytopenia, increased erythrocyte sedimentation rate, reduced complement levels, highly increased level of LDH. The urine excretion of protein was elevated, yet also the signs, the classical signs of activation of the immune system with high ferritin, high triglyceride, and a presence of antinuclear antibodies. And you see that after 3 years from bone marrow transplantation, he fully normalized the levels, the hematological level of hemoglobin, of platelet. The erythrocyte sedimentation rate also was fully normal. Complement levels returned to normal. Proteinuria reduced within the normal range, and there was a clear reduction of all inflammatory signs. So it appears that bone marrow transplantation will be a potential approach to treat patients with lysinuric protein intolerance. But back to the why a webinar dedicated to lysinuric protein intolerance within the ERKNet community. There are two recent papers showing that lysinuric protein intolerance is not only a disorder for pediatric nephrologists, and another one highlighting that membranoproliferative glomerulonephritis in a patient with lysinuric protein intolerance give a lesson to the clinical nephrologist. The conclusion of these two articles was that the nephrologist should always consider lysinuric protein intolerance in the differential diagnosis whenever a patient presents with mixed proteinuria, tubular dysfunction, or chronic kidney disease of unknown origin. We suggest looking for other signs: growth failure, signs of urea cycle impairment, so mild hyperammonemia, pulmonary involvement, hepatosplenomegaly, pancytopenia, hyperferritinemia, lipid abnormalities, and elevated LDH. And the conclusion of the other articles was that although tubular dysfunctions and with nephrocalcinosis or chronic tubulointerstitial nephritis are the most common form of kidney involvement in lysinuric protein intolerance, Also, glomerular involvement with immune-mediated glomerulonephritis may also occur, and immunosuppressive therapy may be indicated. But if this patient arrived to an end-stage kidney disease, what about kidney transplantation? And this is a recent article reporting the outcome of kidney transplantation in a series of patients with LPI in Finland. 8 LPI patients had a kidney transplant at the mean age of 41.9 years, receiving kidney transplant, and 2 receiving a second transplant. Acute rejection occurred after 4 transplants, so 2 of these rejection were T-cell mediated and 2 were antibody mediated. 1 patient, unfortunately, died 6 months after transplantation due to alveolar proteinosis. And the graft and patient survival at 1, 5, and 10 years was respectively 80, 88, 68, 86, and 51 and 50% at 10 years. So in conclusion of this article, the kidney transplantation is a feasible option in patients with LPI, although the acute rejection rate seems high and severe complications such as pulmonary alveolar proteinosis may occur after transplantation. But transplantation also leads to the changes in plasma citrulline and lysine concentration. And in more detail, this recent article shows that the kidney transplantation fully normalized the biochemical phenotype in a patient with lysinuric protein intolerance treated by kidney transplantation. You see here that the reduced levels of ornithine, arginine, and lysine in plasma completely normalized after transplantation. Similarly, the increased level of citrulline returned to normal. Glutamine returned also to normal, and ammonia was within the normal range. So it means that kidney transplantation not only improved the renal function, but also provided a systemic improvement of the metabolic abnormalities classical of lysinuric protein intolerance. So in conclusion, lysinuric protein intolerance causes significant renal dysfunction, in particular the proximal tubular damage in form of Fanconi syndrome, and distal tubular damage like renal tubular acidosis, or a chronic renal dysfunction, renal to chronic kidney disease. And the mechanism, the pathomechanism causing this renal dysfunction is a combination of impaired amino acid transport, immune dysfunction, and cellular toxicity. But all these pathomechanisms are connected together. So thank you very much for your attention. Just to announce that the next webinars within the ERKNet community will be, maybe Francesco can introduce the next webinars. Thank you very much for your attention.
Okay, thank you. Thank you, Carlo. Thank you very much. This was a illuminating, a very complete presentation of this rare disease, but sometimes we encounter these patients, and I think that these diseases are interesting because also of all the physiopathology. Could you keep the last slide, Carlo, please, because I need to announce these webinars. And they're also extremely interesting because we always learn when we analyze the physiopathology of these diseases. So if you have questions, please go ahead and ask them. I will ask them to Carlo in a few minutes. In the meantime, let me just announce the next webinars. The next one will be, so we will have no webinars for the months of May. We will have the ERKNet meeting in 2 weeks, and this is why there will not be a webinar. So in June 10, Haute will talk to us about the recent guidelines that were published. Carlo was one of the authors on the management of methylmalonic acidemia. And then Michael Marlina will talk to us about anti-factor H autoantibodies related disease. And then Elsa van der Longt will give us a webinar of membranous nephropathy. So we have about 10 minutes for questions. The first question, Carlo, is from Lucas Bergenhausen. If I don't pronounce your name well, please excuse me. And actually, it's not a question; it's a comment. He was thank you for explaining this disease. And then comes a question. You said that one can give lysine orally in case of growth retardation, but how is lysine reabsorbed in the intestine of LPI?
Thank you for this question, because it points that lysine has the same transport as arginine and ornithine. And of course, we recommend to use arginine instead of to use citrulline instead of arginine to treat the urea cycle dysfunction. And you're right, but lysine has been used, and there are reports telling that the supplementation with lysine improved the osteopenia, and probably the lysine is involved in the bone metabolism. And for this reason, despite the potential or the technical malabsorption of lysine is still recommended to treat osteoporosis. But of course, I'm sure that osteoporosis is mainly related to the chronic inflammation, as seen in these two patients presenting a very high STS zeta score in relation to high ferritin levels.
And yes, to complement this, Carlo, because some of these patients have borderline low bicarbonate levels due to their tubular disease. And we clearly see that many of these patients that may not have an overt metabolic acidosis, but they have borderline low bicarbonates, usually also have low bone mineral density. I don't know if you want to comment on this.
I think it's a combination, because some of these patients present with a Fanconi or a Fanconi-like phenotype, and of course they have signs of bone disease that is not only an overt rickets, but I think bone hypomineralization can be also related to the loss of bicarbonate, to the mild acidosis, and to the loss of bicarbonates, but also to the loss of phosphate that is characteristic of the Fanconi syndrome. The presentation of macrophage activation and of Fanconi syndrome is always an intermediate level. So I remember the discussion we had with you in terms of, is this an overt Fanconi or is a Fanconi-like syndrome? The same happens with the colleagues from the rheumatology. When we're discussing about the ferritin levels, do the ferritins are characteristic in the range of an overt macrophage activation syndrome? They have something that is in between.
Okay, but one thing that in disease, I mean, by reading, I don't have a lot of experience, but except for the few patients that you showed me, but in reading is the phenotypic variability of this disease. So there are some very, very sick patients and other patients that really have a mild disease. Do you have an explanation for that?
So there is no correlation between genotype and phenotype. This is the first explanation. Unfortunately, we have no genotypes. You see that in Finland, where they have a founder mutation, they have an extreme variability also in the phenotype. So it means that even if the patients share a common mutation, they present with different phenotypes. In our experience, we have no founder effects in the Italian population, but we have seen, I can mention an adult lady who had an hyperammoniamic coma following the ingestion of an high protein and some alcohol during the party at the age of about 25 years. And she had a Lysinuric protein intolerance without clear signs of pneumopathy or without clear signs of inflammation. On the other side, we detected one patient by newborn screening because of mild elevation of citrulline, and this patient had birth in the very first months of life, LDH that was strongly elevated and also ferritin, and he had an activating macrophage activation syndrome following a varicella infection. So it's clear that even in pre-symptomatic stage, like newborn screening condition, we have already the activation of this inflammatory cascade.
Okay, thank you. And just one last question, Carlo. Where are we in gene therapy? You know that, for example, in cystinosis, where the macrophages are very important, there is a current program of gene therapy after bone marrow transplantation. So, bone marrow transplantation after gene therapy. So are there any programs or attempt to do gene therapy in this disease?
I know that in Naples, the group of Nicola Brunetti at TGEM is working in an animal model of LPI. We are collaborating in inflammatory findings in the mouse model, but also Nicola is working in gene therapy for LPI. I think is a good candidate. The problem is we need vectors that are targeted to, not to the liver, of course. We are targeting different tissues.
You know, but I was meaning just a good idea could be to target the bone marrow, because at least you treat the macrophages.
Absolutely. We really understand that bone marrow, that white blood cells were the real target of the disease, following the sad history of this patient that in whom we had a lung transplantation and the relapse of pulmonary alveolar proteinosis following heart and lung transplantation.
Okay, well, thank you very much for this conversation and for having taught us a lot about this disease. I think we're coming to the end of this webinar. I remind you the ERKNet meeting in Leuven. You can also log in online for those of you who cannot come or did not find enough room in the for attending in person. And the webinars in June, we have 3 webinars, 2 webinars in June and 1 in September. So please don't miss them. Thank you very much again, Carlo. Bye.
Bye bye. Ciao a tutti.